Next presenter is Emily Fawcett. She's a nurse at Lenox Hill Hospital, has been here for the past 9 years. She's extremely passionate about international medical mission work, and she found herself on a mission in her own backyard against COVID during the pandemic. We will hear in her presentation, she has traveled to many places where there's a crisis happening because of her desire and passion to help people in need. And because of those experiences and her personality, she came up with Huddles at Lenox Hill, and that made her famous. Emily has been featured on CNN by Oprah Winfrey. Katie Couric has talked about her, and we are very fortunate to have her as part of the lineup today. Emily?
Good morning, everyone, and thank you for having me today. It is an honor and a pleasure to be a part of this webinar. Thank you, Dr. Ortiz, for putting this together and for inviting me to speak. Let me tell you a little bit about myself. My name is Emily Fawcett, and I have been a registered nurse at Lenox Hill Hospital for 9 years. I'm currently on the medical surgical telemetry float pool, and I love it. Every day I go to a different unit. I work with different services and different types of patients. It keeps me engaged, on my toes. It keeps me focused as I'm always learning something new. And I know almost everyone at the hospital. Another huge part of who I am and what I do, as Dr. Ortiz mentioned, is international medical mission work. This is my true passion in life and why I think I was meant to be a nurse. I have been traveling to Nairobi, Kenya for the past 8 years. I run and coordinate free community health clinics in Kibera, the second largest urban slum in the world. The Kibera slum is not recognized by the government, and almost 1.5 million people live in the size of Central Park. There are no public schools, no running water, no sewage system, and little to no access to health care.
Emily, I don't know if you're clicking on your slides. We're not seeing them moving.
Oh, okay. Well, I haven't started just yet,
Okay.
but okay. Thanks, though. On average, my team of 10 medical professionals will see and treat approximately 700 patients in the course of 3 days. Other past medical missions that I have been on include a mission to Haiti, responding with Northwell to Puerto Rico in response to Hurricane Maria, and being aboard the USNS Comfort in South America for a month responding to the Venezuelan migrant crisis last August. Medical missions have taught me a lot. They have taught me to be adaptable, flexible, a fast learner, to be a leader. They have taught me to roll with the punches, to have a backup plan to my backup plan. They have taught me to respect others and treat everyone with the same kindness, and that all lives matter. Little did I know, all my past mission work would be preparing me for a future mission of a lifetime in my own backyard, and what would become the epicenter of this pandemic. The start for me was March 14th, 2020. I picked up an overtime shift in the emergency room this day. It was still eerily quiet, the calm before the storm, but something was brewing. I felt it, we felt it, without really knowing what we were feeling. I remember this day very clearly, a Saturday. COVID was just starting to sneak its way into our city. It was like an uninvited guest, but we still did not really know it was here just yet. And bam, one of the hospital's first critically sick suspected COVID-19 patients comes through the doors. Immediately, he gets intubated. His SATs were low, even on the ventilator. His chest x-ray looked horrific. It was with this patient that I learned just how scary this unknown virus is, how it can change a person's life in a second. This was the start. I just knew. My gut was telling me we would soon find ourselves in the same position as China and Italy. New York would soon be on the news, and we would soon be the headline. I would soon find myself in my own mission in my city, New York City. March 16th, 2020, I hit the ground running. I was one of the first COVID nurses here at Lenox Hill. I was assigned to normally what is the medical ICU step-down unit, but now the COVID step-down unit. The 7th floor was one of the first to become completely COVID. I saw a lot over the next 2 months. I felt a lot. I had a lot of emotions. I saw people die alone. I saw my coworkers stricken with anxiety. I saw New York City come out and rally for us every night at 7 p.m. I saw coworkers get sick. I saw tears. I saw one coworker watch her mother die of COVID. I saw sadness. I saw setbacks, but I also saw triumphs and love. I heard constant sirens outside. I saw the ice truck roll up to act as our morgue overflow. I saw scared and alone patients. I saw family members begging to come visit their loved ones. I held the hands of the dying. I cried with families over FaceTime. I worked countless overtime shifts, 11 to be exact, in a month and a half. I heard the endless rapid responses in code blues overhead, and I had my eye constantly on the COVID graphs and charts, and I was glued to the news briefings. I was tired. I was scared. I was imagining the peak. I was imagining what it would look like if we ran out of vents. I was imagining patients in the hallway and auditorium. I was imagining how we would ever make it through this. I was thinking of all the lives that would be lost and all the grief-stricken families. I was living at the hospital during that time, barely sleeping, but there was no other place that I wanted to be. I wanted to be there, be in the fight. I needed to be there to defend my city against this virus. One of the scariest days we had was April 1st. Talk about chaos. This day, our oxygen supply went critically low in the entire hospital because almost all of our patients were requiring supplemental oxygen, and we had many, many vented patients in-house. I'm sure many of us here today remember this day, have that beeping alarm etched in our minds. But we somehow pulled through. We made it through this day purely because of fast thinking and teamwork, but it felt like wartime nursing. I have many COVID stories that I find myself holding on to. Certain shifts, certain memories, certain patients. Stories I sometimes share with family and friends, but sometimes I choose to hold these stories close to my heart and keep them as mine. Do my friends and family truly understand what we went through? I figure this audience will understand them, so here are a couple of those stories. My Navy vet story. I had the honor and privilege to be a part of a beautiful send-off of an actively dying Navy veteran. You might wonder how death, especially from COVID-19, could possibly be beautiful. Well, this was beautiful. We knew his time was near. We called in his family, his son, a cop on the front lines as well, and his daughter. With the help of management, we gathered the staff. We gathered a Navy vet who had been working that day. We all suited up in our PPE along with the family. Goodbyes were said. He was thanked for his service. We saluted him, and with the Star-Spangled Banner playing in the background, he took his last breath. It was truly beautiful. He taught me that amongst all this pain and sadness and suffering, there is still beauty and love and dignity. My husband and wife's story. Remember my first critically ill COVID patient I saw come in through the ED I talked about earlier? Well, I ended up taking care of his wife for a week. While he was intubated, maxed out on pressors, extremely sick in the ICU, I had the wife on the ICU step-down floor. They were literally a hall apart, but could not be together. I had such little hope for the husband's recovery that I even went through the lengths to get healthcare proxies made for both of them if it came down to neither of them being able to make decisions. I cried with her, prayed with her. I forced her to eat and to sit in the chair. I brought her crossword books to distract her, even if just for a moment. And after nearly 2 long weeks, he started to improve. He was weaned off the vent. And after returning to work after a couple days off, I found them together, sitting next to each other in the same room, with plans to go home in a few days. He was the one that taught me not to give up on someone and to hold on to hope. I soon found myself on a new mission, and I was very determined. I was now on a mission to spread hope. Hope Huddles started from a late-night text thread I was on with some emergency room nurses. They were telling me just how upset they were, how it seemed like there was no end in sight, how it was sick patient after sick patient, intubation after intubation, vent after vent, the anxiety, the unknown, the tears. One nurse even told me she cried for the first time in her 10 years at work. The ER staff was on the true front line. They were the ones receiving these sick patients, admitting these critically ill patients to upstairs COVID units, never knowing if they live or die, assuming that most of them died. I felt a strong urge to develop a way to spread our positive patient outcomes around the hospital, especially back down to the emergency room. And so, Hope Huddles was born. A simple yet effective way to close the loop, to get the information back to the staff of our successful extubations, of our amazing patient outcomes, stories of patients waking up and FaceTiming with their loved ones, stories of patients being reunited with their families, a simple huddle, sharing the good news, sharing some hope. That was all it was. But these hope huddles became our lifeline. What have I learned? Well, I have learned a lot from COVID-19, as I do any mission, that we are adaptable, that we are flexible, we are innovative, that we do not give up, and we will fight till the end. We created surge units in unused areas of the hospital. We deployed staff to areas they do not normally work. We created a swabbing team. We created a system to easily obtain PPE. We created a proning team. We learned how to treat and manage this disease. The list goes on and on. My hospital came together. We were a united front, and we were able to solve most problems and obstacles that came our way. People were stepping up. I was stepping up. New York was stepping up. I learned that people really do rise to the occasion. I have learned that Lenox Hill is truly like a family, my work family. I have learned that we truly are made for this, and that not even a pandemic can crush the human spirit. Now the question is, how do we move on and recover? I think the answer is we don't really, we just find our new norm. Or maybe we do, I'm just not sure. I know we are doing better, and we are way on the other side of the peak. Our numbers are way down, and we did find the light at the end of this long, long tunnel. But we should not forget what we just went through. We should not forget the lives lost. We should not forget the bonds created with our coworkers, with our hospital, with our city. We just went to an unexpected war together against COVID-19, one none of us signed up for. And now we are coming home from that war, and we have to figure out, where do we go from here? How do we heal from what we just went through, what we just witnessed? We lived and worked through a pandemic, and we still have an ever-looming threat of a second surge. I think it's important we hold on to hope. Hope might be the only thing we have right now. Hope that we will overcome this. Hope that we have changed for the better from this. Hope that this has given us some perspective on life. Hope for our future. New York will start to heal. Hospitals will start to heal. Communities will start to heal. And all of us here today will start to heal. And we will eventually recover from this, hopefully stronger and for the better. Thank you again for you all being here today, for listening to my stories, my perspective, my nursing perspective. May we all carry a little hope with us. And thank you so much, and stay well.
Wow, Emily, that was tremendous. That was very honest, moving,
Thank you.
raw presentation. I'm sure there's a lot of people crying here, but we cannot see their faces. Your presentation was filled with words of wisdom. Babies showed up. And definitely inspiring. I see the chat. I don't know if you have an opportunity to watch this. Everybody's sending beautiful messages of how
Thank
moved
you.
they were by your words.
Thank you.
I'm sure David wants to say something because he showed up. We cannot hear you, David.
I wanted to thank you, Emily. You know, I've been watching from afar what you've been doing at more than social distance. And I think that what you've expressed is this kind of unseen toll that this has taken, both negatively and positively, on all of us. And that the way you expressed it was something that I think is so necessary. You know, we have the data, we have the hardcore, kind of the structured record, but it's the unstructured stuff that was unanticipated. And I think there is benefit to this. And I really appreciate and respect everything you've done and you continue to do.
Thank you so
Really,
much.
really special.
Thank you.
Actually, there was someone that made a comment and a question. Said, Emily, this is a beautiful presentation. Would you ever consider collaborating with a professional actress who might be able to turn this presentation into a performance-worthy monologue that could be shared to a larger audience?
Wow, absolutely.
No, and people need to know, actually, Emily is actively moving from her apartment today. So she, these are parentheses in her very active and hectic day. But Emily, we're proud to be able to be co-workers with you.
Thank
You definitely, your passion and desire to help is moving and inspiring to all of us.
Thank you so much.
Thank you for
Thank you.
participating.
Thank you.
Okay, so that was great. Moving forward, next presenter is Dr. Daniel Baker. He's the medical director at Lenox Hill Hospital and as well as the Manhattan Eye and Ear and Throat Hospital. He oversees all medical affairs, quality, patient safety, and standards of care. Dr. Baker previously served as the hospital's Associate Medical Director and Vice Chair of Emergency Medicine, a role he assumed in 2013. He joined Lenox Hill in 2007 as an attending emergency medicine physician, and he has served in several other leadership roles of progressive responsibility. I had the pleasure to get to know Dan a little bit closer when we were enrolled in a program for 2 years, from 2015 to 17. It was a leadership program, and definitely Dan exuded those great qualities of a great leader from the get-go, from even the introductory day for everybody. And from then on, he went into an administrative pathway. He went to complete an MBA at NYU, and now we're fortunate to have you as our medical director. And I don't know if it's fortunate or unfortunate for you, but your first big test became COVID. So
Absolutely.
I guess we will hear your perspective, the Lenox Hill Hospital response to a pandemic. Dr. Dan Baker.
Sure. Thank you, Robert, for those very kind words. Much appreciated, and thank you for having me here. Let me just start sharing. I also wanted to say thank you to Emily. I couldn't agree more with everybody. The sentiment of hope is so powerful, and thank you for bringing that to us. And thank you to David and the entire Department of Neurosurgery for having this conference and allowing me to talk. So I'm going to just take us through a little bit of Lenox Hill's response to the pandemic. Certainly, as Dr. Ortiz stated, it was not something I originally thought I would face as a medical director. But when we took a look at what the response was, we really found 4 fundamental principles. The first was surge capacity creation. We knew that there was going to be a surge of patients and we needed to have room within the hospital to be able to take care of them. The second was creative staffing models and organization of those models. Equally to having the capacity of caring for the patients, we needed to make certain that we had the team members available and the expertise available in order to do so. The third was standardization and advanced clinical care. We really wanted equitable care applied to every single patient who came in. And so it was very key that the care was standard. And we also wanted to be on the forefront of the literature and the science that we were finding out on a daily basis about this particular disease. And then the fourth, as with any particular crisis, communication is absolutely key. And so proactive multimodal communication was an absolute instrumental component to how we were able to share what was going on. So looking a little bit about surge capacity planning, the most important piece here is everybody just said yes. And that is something that was applied really across the entirety of this crisis. Everybody participated, everybody said yes, whether it was closing units, opening units, creating units, staffing, etc. So we actually began this very early in January, and we coordinated with regional and Manhattan facilities. We did an inventory, which you can see in the top right here, with every single unit at all of the facilities. We took a look at both clinical and non-clinical areas. We said, what were these spaces? What are these spaces? What can these spaces be? And can they be med-surg, ICU, telemonitoring, how many beds, etc. So there was a real very thorough assessment of all the different spaces across the hospital. And then that was put into a flexible plan of how we would use these spaces. Flexibility was absolutely key during this. We knew that volume was going to come in the face of COVID-19, but we didn't know exactly what level of care it was going to be, and we didn't know how that care was going to morph over the time frame in order to be able to use different areas of the hospital. A couple of examples of that, this is the 3rd floor plan of Lenox Hill, which is primarily outpatient radiology as well as our cardiothoracic ORs. But on the Wallman building, there were 2 ambulatory pieces, both the ambulatory infusion center and our breast and plastic surgery centers. And these were areas that were occupying what many years ago was a clinical space, but had been modified for their ambulatory care. So we saw that this was a new area that we could turn back into a clinical unit. we were able to decant both of these centers over to Manhattan Eye, Ear, and Throat Hospital. And then we began with facilities the process of building this into an actual inpatient unit. On the right here, you'll see that the rooms were very basic. We built them to really be pluripotent in terms of the care that they could offer. We wanted them to be able to do ICU, we wanted them to be able to do telemetry or med-surg, so that we could really open them and close them in any way, fashion, or fill them with the different patients as they came. But the monitors you can see were actually mobile so that they could be moved around. It's a very bare bones room, no TV, none of the accoutrements of a room, which at your ICU level of care wouldn't matter, but for your med-surg care, for somebody who can't have visitors, is really there alone, becomes a bit of a detriment. And so that's where we look to other technologies. The middle picture here is of what would normally seem just to be a window in the door, but many of our doors didn't have windows. When you look at traditional med-surg care, the door can often be open and accessible, so you have great sight lines and visualization of the patient. But with COVID care, the door always had to be shut. So our facilities team very quickly went to almost every single door in the hospital and put in these window kits. And then very similar to many hospitals across the country, those window kits then became mechanisms to communicate what was actually going on with the care, often with the level of oxygenation as well as what oxygen support was being offered. And you can see that now there's a sight line into the room where we can see the care being rendered. And the picture on the left is essentially what the unit looks like. You can see the change in the floor, which was where infusion center met the breast and plastic center. It was not designed initially for inpatient care, which is why the nursing stations were with chairs in the hallway, and all the rest of the equipment was put there as well. Another unit that we first inventoried, but then had to change what we were going to use for as the crisis progressed, was the 11th floor of the hospital. And here is our cardiac cath floor. And we also had cardiology offices as well as a clinical research space. And this clinical research space occupied a big open area that, again, many, many years ago was actually an OR recovery space. So we found as the disease progressed that our clinical care teams were very aggressive in the ventilatory management and applying non-invasive techniques and high flow nasal cannula, but those needed to be a negative pressure. And we had long outstripped our negative pressure rooms across the hospital, and so we needed something that was a little bit more robust. So our facilities team created what we call the monster, which is on the left, which made the entire unit, not just this open bay, but the entire unit negative pressure. That greatly increased what we could do there from the form of advanced respiratory care. The open unit, we put in this entire nursing enclosure for actually the entire care enclosure. This was kept at positive pressure so that our clinical care teams could go in with direct lines of visualization of all of the other patients. Really impressive on the facilities team. As with any of these things we built, we brought the clinical care teams to the unit and said, help us design this as best to meet your needs. Very importantly was the fact that we utilized our Manhattan campus in totality. So it wasn't just at Lenox, but we used Manhattan Eye, Ear, and Throat Hospital as well as Lenox Health Greenwich Village. At Meath, we had sent our infusion center and set that up in their intake for surgical care. Our breast and plastics operated out of a very small space. And then we created an entire plan to move all of maternal child health over to Meath. And that was an exceptional undertaking. It required a plan for laboratory, for blood bank, for turning the ORs into postpartum care. And Meath would have had a new milestone in the longevity of that hospital, which would have been the first baby ever born at Meath, had we actually executed it. At the last minute, we found that we could find actually another additional 100 or so beds, and so we didn't need to actually go through with that. But the exercise was really profound in doing so. We took the perioperative staff from Meath and we redeployed them at Lenox Hill. And then another unique piece was that we created what was called a COVID patient awaiting placement, or a CAP unit at Lenox Health Greenwich Village. Lenox Health Greenwich Village is a standalone emergency department, but also has radiology as well as ambulatory facilities. And the fourth floor is an ambulatory surgery center. And facilities, once again, worked magic and turned that into an inpatient unit that was capable of both COVID and non-COVID care. Early on, the regulation stated that to return to skilled nursing facilities or subacute rehab, you had to have 2 negative COVID PCR tests. So there was a time frame that those patients were going to be sitting in beds and causing a capacity constraint of the influx of patients. So we were able to successfully move them down to Greenwich Village, which was a very impressive effort. The unit was really staffed by our orthopedic PAs, a medical director that came back to the health system just to do so, and an incredible group of nurses. One of the most impressive things that was done as a health system was what we call load balancing. As everybody is aware, there were different areas of the region that were hit harder than others with regard to the total numbers of patients. And the graph on the upper right shows the percent of patients that are testing positive for COVID-19 with a heavy emphasis in Queens and in Brooklyn, but Queens really being an epicenter of the epicenter. And as a health system, we had two hospitals that were located there, both Long Island Jewish Forest Hills Hospital, as well as Long Island Jewish Valley Stream Hospital. And they were entirely overwhelmed with this. The influx of patients that came, it was enough to overwhelm any hospital. And the health system acted very quickly to decide that what we needed to do was transport patients out, transfer patients out, and then balance them across the entirety of the health system hospitals. So what you see in the bottom graph is that there was a kind of steady state flow of transfers that was normally happening. And then the end of March, this just went up to around 30 to 60 transfers a day of patients coming out of those facilities. It was a remarkable achievement through our centralized transfer center with the use of FEMA ambulances. There were teams at every single hospital. We knew that we were not just a Lenox Hill family, we were a New York family, a Northwell family. And as you can see with the receiving facilities here, Lenox Hill Hospital at one point was the #1 facility receiving patients from both of those hospitals. All told, we received around 200 patients from our Queens hospitals. Just again, a testament to the pure will and resilience of our team members for doing so. They continue to always say yes. This graph just really represents how COVID came into our hospital. From the far left, March 1st, where all of the blue represent non-COVID patients and the orange represent COVID patients. We had our first patient actually come to the health system, excuse me, to Lenox Hill on March 7th. And then you can just see this remarkable explosion of COVID patients where the hospital became very much a COVID facility. And it remained that way until we started to see the plateau and then subsequent the down turn that we have seen in recent days. But again, really remarkable. We saw unit after unit turn from non-COVID to COVID. And then our surge capacity just continued to increase with the additional units that were made. So turning now to creative staffing models and care team innovation, really the moniker here was that no one was left alone. There was an analysis of the available clinical team members from across the hospital, as well as all of our ambulatory settings, redeployment strategies that were created by our department chairs, and then an assessment of the clinical skill set by each and every one of our team members to ensure that there was a safety of where we were going to be redeploying everybody. We had emergency privileges granted, and then multiple specialized teams that were created due to the unique nature of care that was offered for COVID patients. Many of these teams you can see on the right. We had an intubation team made up of our anesthesia department, a swab team that was made up of some nurses and some ACPs with expertise in actually doing the NP swab, a prone positioning team that was made up of our orthopedic surgeons, line team that was most of our non-medicine surgical residents, clinical nurse liaison, which was instrumental in family communication, and then a command center team that sent with our bed control to really allow for great throughput throughout the hospital. So on the nursing side, there was a very robust effort to categorize everybody and structure all of our nurses into 3 tiers. Tier 1 were nurses who were most recently in an inpatient unit care. So they had transferred out of an inpatient unit, perhaps to go to perioperative space, and they had done so within the past 18 months. And those nurses were then just redeployed back into clinical units. Then we have tier 2, which were nurses that had been about 18 months to 5 years out of an inpatient unit, and they required a needs assessment that was performed, and they were placed in a dyad model. And this dyad model was a unique approach of pairing these tier 2 nurses with a clinical inpatient unit nurse so that their ratios were shared. So you know, it's a 1-to-6 ratio traditionally for our regional med-surg model. It wasn't both nurses taking 3 and 3, it was both nurses collaborative taking 6. And that was really, again, speaking to no one left alone so that we could assure that the care was rendered appropriately. And we had the third tier, which was nurses that were about 5 years or greater out from working in an inpatient clinical unit. And so they were redeployed to a non-direct clinical care role, equally as important. Our clinical nurse liaisons, again, with family communication, our distribution team for equipment and PPE, N95 fit testing team. We changed N95s about 2 weeks into this, so we had to refit test around 3,000, 4,000 people. And then our RN Command Center that really kept up with our daily staffing needs. On the ACP and physician side, I would be remiss if I did not thank 3 key people in terms of the continuous staffing of these units. Dr. Linda Kirschenbaum, who really staffed and managed the ICU and telemonitoring units. Dr. Naz Ilyas, our chief hospitalist, who did the same for our med-surg units, and Chris Anderson, our senior director of PA services, who just really redeployed our PAs across the continuum. Very similar here, assessments of the performance of clinical skills, ensuring that we had the right expertise, and really no one left alone. All non-intensivists or non-hospitalists were always assigned to the same unit to ensure consistency. They were done in 1 to 2 week block time periods, and they had full support of an intensivist or a hospitalist there so that we could make certain that they had the backup that was needed. Our critical care fellows and our senior medicine residents were absolutely integral in this. They allowed for this continuum of coverage on all of our units. They maintained our normal practices of escalation or the care that was performed normally on our medicine teams, as we had influx of cardiologists, surgeons, anesthesiologists. They weren't familiar with those same patterns, and this is how we maintained that. And then our non-medicine residents, equally just very impressive in terms of jumping right in. Our surgical residents were doing that immediately, first working on our inpatient units, and then really going towards our more specialized teams and offering their expertise with lines. Our ACPs, equally just really incredible effort, showcasing what ACPs can do. As you can see in the graphic over here, they were put together into different teams that were commensurate with the skill that was needed to man each one of these teams. It was an extraordinary application of these clinical teams from the nursing, ACP, and physician all across the hospital. Going to standardized and advanced clinical care, the most important piece here was really the equitable application of this care. Many of my colleagues have spoken about this care piece earlier, so I won't spend a huge amount of time on it. But most importantly, there was an offering of training and orientation for any clinician that was involved in COVID care. So if you were volunteering, getting redeployed, going to be part of a COVID unit, there was an orientation piece and a training involved. The treatment pathways that were applied were continuously updated by expert consensus and really the evidence-based literature that continued to come out globally. Our COVID units were maintained as closed units. We wanted to make certain that the care, again, was standardized to each and every one of the patients, and the best way of doing that was to manage these units as closed units, and so they were really primarily done by, again, our intensivists and our hospitalist team. And then we also realized that everybody was interested in this disease. How was it progressing? How were our patients doing? What were the difference in the care of these patients as opposed to other viral respiratory illness patients? And so there was a aggressive start to virtual multidisciplinary grand rounds, both here at Lenox Hill as well as over the health system, where we had everybody participate in understanding what this disease looked like. Some of the pieces I think that our teams are remarkably proud of, they were very aggressive with the short course pulse steroids, which we're seeing in the literature start to come out as being very effective. The use and manage of TOSI as the interleukin inhibitor and timing that appropriately to really prohibit the cytokine storm. Aggressive ventilation techniques. Our pulmonary and critical care teams were amazing about this. The beginnings, we had heard about not using non-invasive ventilation, and they really showed us how we could do that and do that in a safe manner, and how it was going to have a positive impact on our patients, as well with the use of high-flow nasal cannula. Multiple clinical trials with the use of famotidine, convalescent plasma, just a really exceptional work there. We matched our testing to support the clinical acumen and suspicion. And then, as Eve spoke to earlier, we had this clinical discharge care navigation, which was exceptionally helpful. This is just an example of what the pathway looked like. It was standard across all Northwell sites. It was very easy to follow, very easy to read, and that was the intent. And again, making certain that the care was equitably applied. To do so, it was also integrated into our EMR, including all of the different clinical trials, so that it was very easy for each and every one of our clinicians to see who would meet the trial inclusion, how to get them in there, and then how to actually order that. And then Eve spoke on this, but I'd like to touch on it again. I think it's just something that was very impressive. We knew in the beginning really how to treat the critical care patients, but it was hard to necessarily know in the very beginning, who can you send home safely, both from the emergency department as well as from the inpatient units. And there was a lot of anxiety on the case of the patients about going home. They wanted to stay in the hospital because they didn't want to get sicker. And multiple of our providers were concerned about them doing the same and getting sicker at home. So we secured a bunch of pulse oximeters and then really distributed them to every single patient, excuse me, that was being discharged from the hospital, both from the emergency department as well as the inpatient unit. And then our health solutions team redeployed our clinical nurse navigators that were traditionally towards readmission process to really do a COVID-19 rapid transition program. You can see that they touched around 500 patients. They engaged these patients about 87% within 24 hours. They monitored them for worsening symptoms, and then if they were going to come back, they helped them get back to the emergency department with a very low readmission rate. It was, I think, an exceptional testament to how you could really extend the care from an inpatient arena to the home. And then the last real fundamental was proactive multimodal communication. We felt very strongly that everyone should be aware of what's happening. There was so much coming out in the media, so much coming out from different sources, different hospitals, different service lines, that we wanted to just make sure that there was one message. So we utilized multiple communication avenues to ensure redundancy. We incorporated Microsoft Teams into all levels of communication. We equally wanted team member feedback to come back up to senior leadership very quickly, so everybody understood that we were listening and we were adapting. And then we wanted real-time data available to everyone easily. So we had daily leadership huddles. We were very transparent in our data and our numbers. We held virtual town halls, sent physician-specific emails out, particularly to our voluntary providers, so that they were aware of everything that was happening inside the house. And then really a robust family communication teams. Taking a look at our daily hospital leadership huddles, we had these both at 9 a.m. as well as 4:30. You can see in the picture, this was one of our very first huddles within the first week and first patient, and no one is wearing a mask, not social distancing. As you can see, that morphed over the time frame of the course of this crisis. At the end, everybody social distanced, the majority on Teams, and certainly everybody wearing a mask. But at each one of these, we went over hospital and system updates, our hospital numbers and logistics, our staffing, infection control, facilities, EVS, human resources, and then really an open discussion of any and all issues that were happening. This was just really fundamental in creating and cascading that information so that it was one message to all and really decreasing anxiety. We created a coronavirus readiness dashboard, and this dashboard was accessible to every single team member throughout the hospital. This dashboard had over 65,000 visits over the past 12 weeks, which is really impressive. It was important that we felt that every single person know how many patients we had that were positive inside the hospital, how many patients under investigation, our house census, the ED census, and our ED holds. You can see the total number of admissions that we had, around 1,300, and discharges also 1,300. And then the trend graph of how we spiked up, plateaued, and then decreased. We added to this our Coronavirus Digital Resource Center, messages from our CEO, Michael Dowling, and our virtual town halls. But this was, again, accessible to all. We had separate leadership boards that had much more detail. We had every single bed that was mapped, the capabilities of the bed, whether it was isolation, hemodialysis, ventilation, really allowed us to then place patients appropriately. Multiple trends on our trends dashboard that again showed admission, discharge, mortality, and extubations. And then we got together with Jill Kalman, our executive director, and Irene Masick, our chief nursing executive, and made virtual town halls. We wanted everybody to have, again, the up-to-date information of what was really going on inside the hospital. So everybody felt included and everybody felt a part of our family and the work that was being done. Again, specific emails going out to the physicians, personalized and updating everybody. It was just, again, we have always been a family and we wanted to continue that throughout. And then lastly, our patient, and family communication was just paramount. This is a very hard disease to care for, given the isolation that is required, both in and out of the hospital, not having visitors and not having that same partnership with family members. So there were daily family calls that were made by our redeployed clinicians and our clinical liaisons. We made use of multiple in-room technologies. We had iPads for FaceTime. Every single room got an Amazon Echo Show where we could communicate both to the nursing stations as well as out to family members. And then really very impressively, and thank you to the neurosurgery department for introducing this, was the use of Playback Health. Very incredible technology solution about discharge information, daily updates to families, and really ensuring that the communication got to the loved ones so that they felt part of the care. Exceptional work by all to really make certain that the patients and the families were included. And with that, we certainly wish that everybody in the region and all of our family get well soon. And I'll open up for any questions.
It was great, Dan. Obviously, you can tell from your presentation how many details went into this, and Lenox Hill was a story of success. And obviously, there's you can see on those slides the leadership, organization, hard work, determination that came into play, and teamwork. So thank you so much. We are running behind on time, so we don't have time for questions, okay?
No worries.
Thank you so much.
Thank you, sir.
So for the next speaker, he will be the last speaker for the morning session. We have Dr. David Langer. He's the chairman of neurosurgery at Lenox Hill Hospital. He's the vice president of neurosurgery for the Western region of Northwell Health. David is a professor of neurosurgery and radiology, and he's also the co-founder of Playback Health, the company that Dan alluded to. David is a superb neurosurgeon. He has a lot of experience in cerebrovascular neurosurgery and endovascular neurosurgery. He is someone that leads by example. And in the past couple of months, when the COVID pandemic arrived, he did just that. He went ahead and went to an ICU, started working the shifts from 5 in the morning at the Jacob Javits Center. And he basically set the example for the rest of the department. David, I've known David now for almost 17 years. And from that moment on, he became my mentor. Later on, my boss, my partner, but much more important than all of that, my best friend. It is an honor and privilege to work on a daily basis next to David, because I know that there's nothing to be afraid of. We're going to be able to conquer any disease and any problem that comes, or any hurdle that comes in front of us. So I forgot to mention, and David now is the protagonist of the Netflix docuseries Lenox Hill, which will be coming to Netflix on June 10th. So we're all looking forward to that. David is going to talk to us about the role of the neurosurgeon during the pandemic. David Langer.
Thanks, Rafa. You know, as I talked to them, this has been a really emotional experience. I don't know if I probably will break up a little bit in this, in all likelihood. And also hearing what you had to say means a lot to me, so thank you. So I wanted to start off by going to maybe the future and why relationships matter. When I was an undergraduate medical student and a resident, I worked with a scientist. Her name is Kate Carrico. Remember that name. She was maligned. She was creative and innovative and wasn't, well, because she was doing things that were kind of off the beaten path, she was a threat to the conventional wisdom. And at the time, we were studying the use of RNA as a drug. The idea would be to deliver an RNA molecule to a brain or to spinal fluid, in my mind, and treat what was then called, what was called cerebral vasospasm. But the idea had to be studied. And so I was working on creating ways of delivering RNA to rat brain. Well, I left Penn, unfortunately, for better or worse, in 1998. It may have been the biggest career mistake of my life, because about a year or two later, Kate was doing some control experiments to confirm some of the things that I did. And she realized that there was this massive immune reaction happening when you gave RNA to rats that was unrelated to the message that it was encoding, but that when she used transfer RNA as a control, which doesn't code for any protein, she didn't get the immune reaction. In fact, what she realized is that the reason why that was happening is that the immune reaction was reacting to what's called pseudouridine, which is basically the uracil is attached to the sugar of an RNA in a little bit of a different way. The reason why that's important is it eliminates the immunological response. And that concept in the year 2000 has become the basis of the BioNTech and Moderna vaccination program. And knowing Kate and knowing her way, her intensity, her intelligence, and what she taught me, I'm sure these vaccines will work. I have no doubt. And we have a lot to look forward to once we have that vaccine. And this goes back, 25 years. And you develop a career over a long time. And you meet people along the way, and you gain friendships and colleagues. And I just want to mention this one. This has been one of the most fruitful collaborations and will continue to be. And I just congratulate Roth for putting together this just amazing virtual conference, which potentially is just not only the future, but the positives that come out of this. And the butterfly behind me is representative of that. We have this idea that chaos, as difficult it is, breeds change. And change is what we need to inspire ourselves to change and be better, and like a butterfly come out from this in a better way than we went in. Roth has taught me how to be innovative, how to be hardworking. I continue to learn from him in the angio suite and out. And I think that we've already been successful, and the future looks very bright, not only for the two of us, but for our whole group as we continue to gather steam. I love this sign. And another way to look at this is one person can change the world too. You can look no further than what's happening with George Floyd, that, one person can change the world. And whether you're eating an uncooked bat or having an impact on societal change, we all have that ability with hard work and with passion, empathy, spirit, intelligence, and teams. We know a lot about this virus now. We know how it works. I spent the better part of March learning about this, and thanks to our ICU staff, I basically immersed myself in it. I was sitting at home waiting to be redeployed along with all of us, and realized when we had an oxygen problem at Lenox that I needed my training. I had been trained. I had been trained to act, to initiate. I had training in intensive care medicine. It wasn't what it was in some of our people like Dr. Karpati or Dr. Kirschenbaum, but I felt that I had enough in me and enough background that I could make a difference. So the first thing was to get into the ICU. And one thing that we very early focused on was communication. As a neurosurgeon, we deal with sick and unhealthy and very emotionally challenging cases. And So we offered ourselves up as a communication team, but I knew if we were going to be redeployed, we needed to learn about COVID. So at the same time we were communicating, we were learning from our outstanding IC staff. And here in this picture, our intern, who's actually a dermatology intern on the computer on the right. In the foreground is one of our pulmonologists and a pulmonary critical care fellow. Behind him is Anoop Singh, who's just a phenomenal intensivist who I learned so much from. We have an anesthesiologist here. Benjamin in the back is one of our pharmacists. And as Dan pointed out, we stood up these groups of teams and learned from one another. And I think this has had a profound impact on the environment, the culture of the greater Lenox Hill Hospital as well, as it did really, I'm sure, throughout the city and the country where this sort of behavior happened. You know, my professor in medical school used to teach me that there are 4 kinds of patients in the ICU. Patients who are not sick, sick, very sick, and too sick. Patients who are not sick don't belong there. They were like in a trauma and got intubated in the ER, and they come up and they're fine. They just get out of there. Patients are sick, you can leave them alone and they more or less get better on their own. But it's really the very sick and too sick patients that we need to manage. And I think after living through COVID, it was preventing people from getting from very sick to too sick and avoiding the damage that this viral cytotoxic storm creates for patients. And I think that watching our teams develop a strategy and a tactic really was living medical history. And I don't have to go into the specifics. We've already heard about that. But the anxieties that we were all feeling and the fear and we were waiting for that curve to come down. It reminded me of a story I heard about a Vietnamese general who survived a prison camp with his team. And after Vietnam, a number of his men had post-traumatic stress disorder, while others seemed fine. And so they asked him, what was it about you? And he in particular wrote books and seemed fine. It was, what is it about you that made you overcome such a hardship? And we've seen this in the concentration camps during World War II as well. And what he said was that, you know, he was an eternal optimist like I was, but optimism sometimes is problematic, and that you're always waiting for the end and you're hoping for the end. And that what his solution was not to worry about the end, but that life was going to change and eventually this would change, but this is a continuum. And that by not waiting for the end, accepting for what it is and doing the best you could was his method. And I think that it really resonated with me, and it got me thinking about how to plan for the future and accept the environment we were in and make this better down the road. I stopped waiting for the end. I just assumed this was the new normal, and we moved forward as a team. You know, John Bookvar, my partner, another one of our partners, has an amazing clinical trials team that essentially reinvented itself doing COVID clinical trials. And his team just basically went at it and really ran and got involved with, I think, the majority of the clinical trials at Lenox Hill Hospital, basically treating COVID, which is, I think, testament not only to John and his team, but to the creativity and the value, and again, the training that we have, could be applied wherever it goes. You know, neurologically, there wasn't much for us to do as a neurosurgeon. We learned about the neurological manifestations. We saw them. We saw these different ways that this thing presented. But in general, the management was challenging. These patients were sick. There weren't really great therapeutics for these things. So to expose the staff and the magnets and the CAT scanners to sick COVID patients had real repercussions. And so we didn't really have the ability to make some of the observations that we're making now, because basically we have that opportunity now to continue to study these patients as things have calmed down. And undoubtedly we'll learn a lot more about the different and various ways that COVID manifests, although we have seen a tremendously challenging environment with bleeds and strokes, encephalitis and encephalopathy, and determining how to manage these things more aggressively will be valuable when this undoubtedly returns someday. As Dan pointed out, I think that these next few slides show us what we were dealing with. On the 20th of March, our hospital had a total of 41 COVID patients and 31 under testing, but you can see that house census was down to 294. We turned off all the elective surgery in March, and our normal census is upwards of high 300s in the 400 range. And yet here we were with a 2/3 full hospital waiting for this, as if you're a Game of Thrones fan, for the White Walkers to show up. You know, I'm a huge Game of Thrones fan, and the reason why the White Walkers were real in this case is that the White Walkers were something that was out there that no one thought they'd see, that there were some people saw them and they talked about them, but no one would believe it could exist. It was reminiscent of hearing about Wuhan and hearing about what happened in Italy. But our government at the state, local, and at the federal level, they weren't, it wasn't until it was right in our faces, until the White Walkers were amongst us, that we all suddenly realized what we were up against. And I think New York served as that, if the media was here, New York served as the demonstration of how real this was, and perhaps New York City's experience saved many more Americans than it should have happened in a less media-savvy city. Well, by the 21st, this is what our hospital looked like. We started to get, this was just an incredibly valuable piece of information that Dan and his group put together. But you can see 8EA is our neuro ICU, 70EA is the medical ICU. We started to fill up our ICUs. So literally a day later, and there are now 10 more COVID patients and another 28 under investigation as our house census actually continues to drop as we're discharging the non-COVID patients. You can see the ED starts to have more and more testing patients. By the 23rd, 2 days later, another 10 COVID patients, 46 under investigation. Now we're seeing the house census blow up. You're starting to see all these former ICUs that weren't ICUs before are becoming intensive care units. And also you can see that the number of ICU patients that were intubated is quite impressive, that those small diamonds next to each room number represent a ventilated patient. By the 28th, we changed the dashboard. These were only the units. So now not only was the neuro ICU and the MICU an intensive care unit, so was the CCU, and eventually so were the CT SICU as well. By the 28th of March, we had 143 COVID patients, 25 under investigation. The house census starts to pop. By the 11th, 303 COVID patients. Look at the number of ventilators. It was over 80% of the intensive care were ventilated. Now we have the MICU, the CCU, the neuro ICU, the CT SICU. We extend our intensive care units into other parts of the hospital. This required an enormous amount of engineering support, nursing support, administrative support. Our health system is a massive bureaucracy. And as a clinician, as a physician, it was one of the first times that I saw the value of good administrative leadership. Not that I hadn't seen it before, but without our administrators and without the strength of our overall system, this would have been an untold disaster. And what the team did here and elsewhere in our health system was just testament to the leadership at the top of the food chain. And we're all forever grateful to have lived through this and actually thrived through it and learned from it. You know, Dan showed a slide at the end. By the 17th of April, we were over this hump, but there are continued repercussions. And again, just because this is coming down, this is not over. And going back to the Vietnamese analogy, the Vietnam War analogy, we've changed and we're moving on and we're going to be better for this. And this is not over. This is just the new normal that we're all experiencing, and things will change. I would argue that this was an early article that I read from the American Enterprise Institute. I'm somewhat left of center. This is a right of center article from Scott Gottlieb and his team at AEI. But I think it really was the first report that really demonstrated what was necessary to move our society forward. And New York City is just about to get into phase 2. But phase 4, which is where we're hoping to be someday, is really more than just therapeutics and vaccines. It's going to require a massive change in our thinking. It requires us to think about what's good for the whole. You know, Dan knows the story, and I will never forget this moment. We were trying to get ventilators, and I was working hard with our plastic surgeons in the Upper East Side. There's no lack of plastic surgery in the Upper East Side to get their ventilators into the hospital. And we struggled, and all of a sudden the governor came out and said he's basically going to take them all. And then I was trying to even accelerate this to get the ventilators to Lenox before the governor got them. And Dan Baker on a Sunday night said to me, David, you know, what's important is not that a Lenox patient gets the ventilator. It's that a patient gets the ventilator. That just because a patient on the Upper East Side didn't get one, didn't mean it wasn't going to good use. And while this is a microcosm of the problem, it changed me. And it changed my thinking about the way I behave and the way I focus on the greater good. it's had an intense impact on myself, and I'm hopefully going to be able to continue to use this. But our problems are much greater than ourselves. And we need to think as teams and as groups as we move forward, both here at Lenox Hill and outside. You know, I was lucky enough to participate at Javits. After spending almost 3 weeks in our ICU, I realized that I wasn't going to be needed as an intensivist here. And I actually went to Javits to offer them our communication strategy, which had worked well at Lenox. But when I got there, the last thing they really needed was a Yahoo neurosurgeon with a mobile app. And so basically I said, you know, I talked to the leadership there, and they were sorely lacking experience in managing COVID. I was no ICU expert, but I certainly, after 3 weeks with our Lenox ICU teams, knew more about COVID than the military docs did, who were really trained for conflict and war. And so immediately I was able to be impactful there. This woman on the right was my first patient that I actually successfully extubated based on what I'd learned at Lenox. And to me, this, in many ways, this represents one of the most valuable experiences of my medical life, to have this impact on a single human being. And it was an experience that I think will never be forgotten. And I find that this experience ultimately will pay enormous dividends, hopefully for myself, my family, and the people that I work with. You know, every day we walk outside of Lenox and we see this. Now, these have calmed down a little bit as of late. I always joke there wasn't a lot of social distancing there. What those things taught me was the value, not that I didn't understand the value of our nursing leadership, of the nurses and the respiratory therapists and the unsung heroes of daily healthcare. But these folks and these workers are just as important on an everyday basis as we are, and they deserve unbounded respect. I've watched Emily Fawcett and seen what she's done, and it's really just breathtaking to see the contribution that they've made. Early on, we started using the ideas of what are now called the Butterfly Project here in our department, touching base with Wuhan about what their experience was before we were up to speed at Lenox Hill. And actually, Dr. Luo is there in the foreground. This is how we got him invited here today, earlier at 7:30. But the bottom line is we need to ask for help. We're all human beings. In our midst, we have to be respectful of one another, no matter what our color, no matter what our nationality is. And the fact that this is all happening now with what's happening in our country now is only adding another layer to an already historic situation. So what we did in our department as a neurosurgeon, how do we challenge our team to think forward to March of 2021? Where are we going to be next year? How do we take the lessons learned of COVID and of George Floyd and of the situations that we're in and make a difference by March of next year? So our administrative team, led by Rebecca Wallach and Julissa Reyes, really started looking at every aspect of our neurosurgery department. And we looked at how to use technology and how to overcome some of the limitations of our previous structure. We also have financial issues, but technology is just changing workflow and using technology is much cheaper than bricks and mortar. So we looked at every workflow in our department and we try to use technology as an enabler. And in each of these areas, our clinical workflow, patient education, research, the inpatient journey of patients, training, and then our administrative staff, we worked hard to figure out ways to improve things. At the minimum, at one just way that can be looked at, that's not obvious. Why can't we be the best place for single moms to work? Why can't our department be we learned so much from using remote access and working from home. Why should a woman with a child who's sick at school lose a work day because she has to stay home with her child or loved one? That doesn't have to happen anymore. And that's just the tip of the iceberg. But if you expand upon that concept, just think what the opportunity is going forward. And that's how we get better from COVID. So this has resulted in many different things. Besides our Lenox, obviously our Netflix show is just lucky, but by the same token, that's going to give us a platform. And whether it's our web presence and our Zoom conferencing that we've used, even this conference itself came out of the butterfly idea, using mobile platforms to create movies or asynchronous communication, as well as telehealth and synchronous communication, using technology to train the next generations of physicians and nurses and administrators, using virtual conferencing, and of course, setting an example as leaders of going forward and celebrating not only our strength, but attacking our weaknesses and being bigger than ourselves. That's what we need to do. You know, as I went through this, I was reading a lot, and I think that the David Brooks editorial in the middle of April really served to me as a really an important representation of how to think. He said in this, he was talking about how as parents we coddle our children, and that there's been great inflation and that children aren't taught to fail. But towards the middle, when it became so interesting to me, is he started to talk about medical school education and how that science still matters and that reality matters and that you can't fake how you do in science or in medical school. And he said that I'm also reminded of the maxim that excellence is not an action, it's a habit. Tenacity is not a spontaneous flowering of good character. It's doing what you were trained to do. It manifests not in those whose training spared them hardship, but in those whose training embraced hardship and taught students to deal with it. And I'm just going to end with this, and hopefully I can get through it. I've read this before. Years ago, anthropologist Margaret Mead was asked by a student what she considered the first sign of civilization in a culture. The student expected Mead to talk about fish hooks or clay pots or grinding stones. But no, Mead said that the first sign of civilization in an ancient culture was a femur that had been broken and then healed. Mead explained that in the animal kingdom, if you break your leg, you die. You cannot run from danger, get to the river for a drink or hunt food. You're meat for prowling beasts. No animal survives a broken leg long enough for the bone to heal. A broken femur that has healed is proof that someone has taken the time to stay with the person who's fell, who has bound up the wound, has carried the person to safety, and has tended the person through recovery. Helping someone through difficulty is where civilization starts, said Mead. We add our best when we serve others. Thank you.
Well, David, that was tremendous. That was moving at the end. And thank you so much for your presentation. Beautiful.